Very, very important to prepare for emergencies, things that we don't expect to happen that could happen. So most surgeons will have a list that say, please call if you're experiencing, and these are some common things to see on them. So temperature, and they'll tell you what temperature. Some people say 100.4 or higher, some people 101, do what your surgeon says. Thus the importance of having a thermometer that you have with you in your supplies. If you're not recovering at home, if you're in an Airbnb, and if you're the caregiver, like, I think he feels, or they feel a little warm, but I'm not sure, make sure you have that thermometer with you. They call it asymmetrical swelling over a large area. Asymmetrical just means it's not symmetrical or even on both sides. One side of the chest or labia or scrotum is larger than the other. What I usually say, because sometimes people are like, well, how do I really know? I say it's not your responsibility to know, but if you have a spidey sense, or if you're like, I think this is bigger, then you should call. It's much better to overcall than to undercall. And many places will have you send a picture and they'll look at it and they'll be able to either reassure you or tell you to come in. Severe black and blue discoloration or bruising. How do I know if it's severe? If it looks like it could be severe to you, same thing. Call, they might want a picture, etc. Severe burning pain, that should not be happening. Kind of two reasons for that. So one is nerve pain, but they are pretty good at avoiding nerves in most of these surgeries. And so that would be one reason. And then the other reason is just the pain has completely gotten out of control. So when you're administering pain medicines as the caregiver, it's important to realize that, once the person starts feeling the pain come on, it can exponentially kind of get worse and worse. And if you don't give the pain medicine when the next dose is due, then it may be too late and the pain may have gotten out of control. It doesn't matter how many pain medicines we give you, it may be out of control. It's sort of like a house fire. If the fire just starts in one room, it's much easier if it's, doesn't get to another room or the second floor, right? To put out, it's much easier if it's just in a small area. So same with pain, it's much easier to stay under control if you don't let it get out of control. If you have any questions about how to do this, just following the instructions, they'll say give one every 6 hours or whatever that is. And then, after a day or 2 or 3 or however long, if the person's like, I feel like I can go another hour before the dose, increasing the length of time between doses, switching to Tylenol, seeing if that works. Really work with the nurses and surgeons from that office to manage pain. Severe nausea and vomiting. I always say that everybody gets to throw up once after having surgery. It's a big deal, so if they at one time, just felt a little nauseated or threw up one time, that's fine. But if they're so nauseated or vomiting so much that they can't keep food down, they can't keep their medications down, they might be dehydrated, that really is time to call, and you might need to go to the emergency room to get fluids or to get stronger nausea medicine. Many times surgeons will have you take nausea medicine. It's really common to feel nauseated after anesthesia. And also if you take your pain medicines without food. So make sure you have at least some crackers or something around. That's going to be really helpful. And also to stay hydrated, you want to keep at least a water and some kind of Powerade, Gatorade, electrolyte mix at all times next to you. So you stay really well hydrated and you get up and pee a lot. Or if you have a catheter, that'll take care of that. Bleeding. Really shouldn't be bleeding after they take you out of surgery or after you are discharged to home. If there's a little bit of bleeding and you can put pressure on it and it stops, not a big deal. But if anything more than that, you really need to call. Difficulty breathing or kind of a warmth, pain in the legs could be a sign of a blood clot. Folks, surgery increases your risk for having a blood clot. So it's important to be aware of those signs. Also, one way to prevent blood clots is to make sure when you are able to get up and walk around that you do, and don't just stay in bed all day unless you're supposed to. So for example, after I had top surgery, for me, what I would do was I would make sure I was really well hydrated, and I had my mom, who's a doctor, taking care of me, and her nurse as well. And it was a whole thing, and they did a great job, and we made it through. But every time I had to go pee, I would walk around the hotel room a couple of times. And then a couple of days later, I would walk up and down the hall of the hotel every time I went pee. And then I would get back in the bed and rest. So moving the body is really great to help, move the circulation of the blood, and that can help prevent blood clots. But it can also help your immune system because your lymph fluids move when you move. So helping your immune system is important. And it also helps your bowels move your body, move your bowels. So that brings us to the last emergency on this list. And remember, read your surgeon's list. Severe constipation. Unfortunately, prescription pain medicines cause constipation. It is how the receptors work that these medications target. So any day that you're taking a prescription pain medicine, you should also be taking some sort of stool softener. And that can, different people take different things. It could be Miralax. Sometimes it gets so bad you need a suppository. Make sure you've had that conversation with your caregiver already. But ideally, you'll not get constipated by taking a stool softener every day that you take these pain medicines. If you go a day without pooping, I would double up on whatever that regimen is to keep you not constipated. So if you were doing 1 cup of Miralax, do 2 of the little caps instead, but make sure you talk to your surgeon, and they should be the ones that instruct you on exactly what to do for your bowel regimen. But we really want to prevent that constipation. Some people have been so constipated that they got hemorrhoids when they were pushing on the toilet, and they told me that pain was worse than surgery pain. So we really want to avoid constipation. Also thinking about different foods that you eat that might help you go better. Other things to prepare for in terms of prevention. This is a really important slide. There's going to be a lot of content here. So first is postoperative depression is a real thing that happens to folks. And it's important to have a coping plan. Even if you've never been depressed before, you can still get postoperative depression. If you have a history of depression, you may be more likely to get postoperative depression. Why really is this? Well, when you're recovering from surgery, it's really the perfect storm for depression because you're not able to do the things that you normally like to do. You can't really get out much and go see your friends and engage in fun activities. You're really restricted to the activities that you can do. And you're cooped up in a room, maybe pretty lonely, even if you have somebody with you. So there's really a lot of things that can increase your risk to feel depressed. And then also maybe the surgery doesn't look the way you wanted it to look, like we talked about, because you just had surgery. So it's important to have some coping plans in place, talking to other folks who have experienced this, or thinking about what helps you get out of a funk when you're in a funk. So sometimes people talk about having one thing to look forward to every day. So day 5 after I'm done with surgery, that's when I'm going to call my friend and we're going to have a Zoom call for as long as I feel up to it. Or, this day I'm going to read this book. It's really important to know that there are some activities that you would like to do that you can't necessarily do, like playing games that have a lot of things that move your arms up here, depending on the surgery you've had. So make sure that you know what you are able to do and what you aren't able to do. And then if you have a therapist, it's good to kind of plan a check-in with them the week after surgery and kind of check in to see how that's going. If you've been on antidepressant medicine for a long time, probably a great idea to keep that up during the surgery and recovery period. So just think about coping. And also if you're a caregiver, this is something to be aware of and to watch in the patient that you're taking care of and to help support them as they cope and remind them that things will get better, it will look better. Next is concern about addiction to prescription pain medications or opiates. This is also incredibly important and a very real topic. If you're a person that's going to have surgery and you've had issues with addiction, specifically with pain medicines, or if you're going to be a caregiver and that's your history, and all of a sudden we have pain medicines as part of the picture, it's really important that people feel comfortable with the plan. And so you really want to have somebody who hasn't had a history of addiction, if at all possible, administering the pain medicines and being in charge of those medicines. Most people will not need all of the pain medicine that they are prescribed. And so having somebody that you trust to be able to either bring it back to the pharmacy or however your county recommends discarding the rest of the pain medicines that you don't use will be very important. Also, you really want to make sure whoever is taking care of the pain medicine, that caregiver, is making sure they don't give any more than is prescribed. So if it says every 6 hours, if it hasn't been 6 hours yet, you really shouldn't give more. That can cause a lot of issues. Dilation, dilation, dilation. This is for all of y'all that are getting a vagina. So if you want to keep your vagina forever, even when you're a 70, 80, 90-year-old person, you really have to dilate forever. And each surgeon should give you a really nice handout on dilation, and they should tell you which type of lubrication to use. So make sure you follow that. Really good friend of mine talks about creating Dr. Evelyn, she recommends keeping a dilation playlist. And so for however long you need to dilate for, once the playlist ends, you know, it's done. And so that can, you know, help you with dilation. We talked also about pelvic floor physical therapy. So make sure that you are working with a pelvic floor physical therapist to help you dilate. Other things that I've seen throughout the years are people say, oh, well, you know, after it's been forever, then you just have to dilate once a week unless you're having sex. So penetrative, insertive vaginal sex, then, you know, then I don't need to dilate anymore. And this is what I have to say to that. Dilation is when you take something, a dilator, and you put it inside the vagina and you leave it there for X number of minutes or hours, depending on the instructions. When you have sex, penetrative vaginal sex, that's usually not the same thing that happens. And so prolapse is the concept of when the vagina folds in on itself and comes out of the body, if you will. That can happen if you're born with a vagina or if you get one through surgery. If you don't dilate as instructed and you are, or somebody tells you, oh, you just have sex, you're more likely to have vaginal prolapse. And once it's out of the vagina, much harder to keep it in there and keep it clean and sterile, etc. So make sure that you dilate and you realize you're doing this forever unless you don't care about having a vagina anymore, and then know that you might not have one anymore. So dilation, dilation, dilation. This is a lifetime commitment to your body. Make sure that you also, if you're getting a vagina, know what type of tissue will be there, whether it's using your colon, whether it's using skin grafts, whether it's using peritoneum, and make sure that you're able to have a discussion with your surgeon about upkeep and washing, cleaning, maintenance. In general, people who are born with a vagina, they tell them, don't douche, don't ever douche. However, it may be different depending on what your vagina is made out of. So make sure you get some clear hygienic practices. Like, am I supposed to, you know, use something to put water up there or soapy water every week, or what's the plan? So make sure you know your plan once everything is healed. Talk to whoever is going to be your caregiver, your significant others, about the impact of surgery on your relationship. I've had people surprised that, you know, one particular surgery just set off a family member and now they don't talk to him anymore, even though they had a different surgery earlier and that family member was fine. And that was really stressful for them. And now they don't get to see their grandchildren anymore, but there was no conversation, you know. So really talk to significant others about the impact of surgery on your relationship. Talk to the person who's going to be taking care of you, caregiver. Talk about concerns you have, communicate, communicate, communicate. We really want to prevent as much as we can. Things still happen, but really, you know, talk to each other about how this is going to affect the relationship, and that's recovering from surgery and then also after surgery is done and healed. The other thing that I really strongly suggest is that you practice taking steps toward loving the body you have now before surgery. Some people think, oh, I'm going to get this done and then I won't have dysphoria and then I'm going to love my body. But the issue is the brain doesn't work like that. It's not such a quick turnaround. It's important to work on loving the body that you have right now as you're waiting for surgery. Because if you associate your genitals with, I hate this, or this makes me not really a woman, or, you know, all the different things that we might have in our head, and then all of a sudden you think you're going to wake up one day and those same thoughts are not going to be associated, that's not realistic. They will. The brain doesn't work so quickly like that. So it's important to work on loving your trans body, loving the parts of you that make you trans, because the world tells us not to. Laverne Cox talks a lot about that. I find inspiration from her, and then a Luck as well, different folks online. So just work on learning from our elders, learning from our poets and prophets in our community to take steps to love the body that you have right now, so that it'll be easier to do so after surgery as well. And the way that you talk to your body impacts your body's ability to heal itself, and so make sure you work on self-talk and loving the body you have now. This can also be related if you're having genital surgery. If you've never had sexual pleasure or orgasm before you have genital surgery, it may be more difficult to do so afterwards. We don't know, but it's important to figure out how to have orgasm in your body before you have surgery, so that you can make sure all of those neural connections and everything are all set up nicely, so that then after you have surgery, however long they tell you to wait, you should wait that long before you try to have pleasure and orgasm. But make sure, if at all possible, that you're able to do that before surgery as well as after surgery. Get a system in place. All right, caregiver. This is the system that my mom, who's a doctor, and her good friend, who's a nurse, kept for me. And it's a lot of things to keep up with. And you might need to have more than this written down in one place. Record the medications, the dose, and the time that they gave the patient, and when the next time it's due, because a lot of times your pain medicines and your antibiotic medicines are going to be on a different schedule. One might be every 8 hours and the other might be every 12 hours. And that can get confusing. And one might be give with food, one might be give without food. So make sure that you know what to do there. Usually pain medicines are given with at least a crack or something, so they don't cause too much nausea. The pain medicines, you don't have to take those forever, just until you don't need them anymore. But the antibiotics, you got to take every single one exactly as prescribed until they're gone. Very important. Any day that they're taking a pain medicine, they need a stool softener. Miralax is the most common one. Work with a surgeon to figure out what stool softener that they should be getting. We talked about vitamin C and zinc already. If they have other medications that they're supposed to take, make sure that you're reporting those and that they've gotten them every day as prescribed. Intake, how much water or different things are they drinking? How much food, what are they eating? We talked about food can be healing. And so making sure that you're trying to get a good mix of healing food in there, fresh fruits and vegetables, anything they can do. It's hard when you're out of town, but seeing what you can do to make that healthy and healing. Output, I really hope by now the caregiver and patient can talk about bowel movements if we're doing all of this. So make sure they have a bowel movement. If they don't, the next day they need to increase that stool softener. And again, check in with your surgeon about that in your particular case. If they come with a catheter, then make sure that you know if you're supposed to measure how much comes out of that. You can keep track of that there. If they come home with drains, same thing. There usually is a whole nother sheet for you to keep track of drain output, but if not, you can keep track here. If there's more than one drain, make sure you keep separate track of how much and what color in each drain. Dilation, make sure that you're adhering to the dilation schedule. And then a place to write down any complications. We did this whole day 0, day 1, day 2, day 3, but you can say like Monday, Tuesday, you can call it whatever you want to call it, but get some sort of a system that's centralized so you can keep this information all together. It's a lot of information, and caregiver, we really want to decrease your stress. So make sure you have it all in one place. And then everybody, caregivers and patients, connect with community, people who have been there before. There's a lot of valuable lessons learned. So make sure that you connect with folks who've had the surgery before. There's all sorts of online groups, Facebook, Discord, Reddit, you name it. There's plenty of groups all over. In-person meetings and conferences are also a great place, if at all possible. Support group meetings, people who know people who've gone to that particular surgeon, really, want to get some information from your community. Caregivers talking to other caregivers. Many people that I talk to say, oh, they've never met another person who took care of a transgender person, or they've never met another person who has a transgender child, or they've never met another person who had a transgender partner. This is the time. Get connected, meet other people who have been through this before. That can be so helpful. I hope that you've enjoyed this information. We'll keep making content depending on what folks would like to hear about. I'm really excited that you've chosen to watch all this information, and I wish you the best in your surgery process. Y'all take good care.